You'll be with us all day, huh, Ms. Cantwell?
I am.
We definitely intend to continue the conversation about the COLA, having come from the nonprofit world where you're often told to do more with less, certainly sensitive to the concerns about that. So duly noted. Thank you, speakers, and just keep in mind that this is a conversation we intend to keep open going forward. Let us move on to healthcare reform implementation issues, please.
Sure. So the subcommittee requested that we provide an overview of the major fiscal impacts on the budget of the ACA implementation, and then there was a specific question related to covered California to Medi-Cal transitions. So we have already touched base on some of the major impacts to the budget due to the ACA implementation, the single largest impact, of course, being the increase in enrollment due to the expansion as well as the changes in eligibility enrollment processes. In addition to those changes, other major impacts due to the ACA or really related to the state's implementation of that include the benefit expansions in mental health, substance use disorder treatment services, adult dental services, behavioral health therapy for children, and preventive services. We've also had the implementation of hospital presumptive eligibility, which allows individuals to go into hospitals that have requested to participate in the program and to get immediate coverage into Medi-Cal while they wait for a full application to be adjudicated. And then finally, a third example would be the expansion of full scope coverage to pregnant women up to 138% of the poverty level. The agenda specifically talked about the transitions from Covered California to Medi-Cal. The January 2015 transition of enrollees from Covered California to Medi-Cal was necessary in part due to a lack of systems functionality to enable enrollees who appear to now be Medi-Cal eligible to remain in their Covered California plan until their final eligibility was determined. I do want to note that there will always be regular transitions of individuals every month who have eligibility changes. But for the time being, the transitions include two groups of individuals, those who've been determined eligible for Medi-Cal and those who, due to a change in circumstance, appear to be Medi-Cal eligible but are still waiting a final determination. Eventually, that second group will remain in their Covered California plan until their final eligibility is determined. But due to the system issue I mentioned, Covered California is currently unable to keep these individuals in their Covered California plan. And so to ensure no gap in coverage, we agreed to enroll those individuals into Medi-Cal. This population is enrolled into temporary aid codes pending their final eligibility determinations. The other group, those with a final Medi-Cal eligibility determination, will continue to transition each month and are enrolled into whatever their appropriate final aid code is. For both groups, to ensure as much continuity of care as possible, we are enrolling those individuals directly into a Medi-Cal managed care plan immediately and then notifying them of their options to change plans afterwards. We really viewed this as a way to help ensure someone has some place to go and a plan looking out for their care management during that transition instead of having that break into fee-for-service. As noted in the agenda, the January transition population was about 100,000 individuals. That's obviously a lot of individuals. It was a challenging transition for those beneficiaries and for our systems and our health plans. We are seeing now we saw for February, and now we're looking at March, that we are seeing the number be around now 6,000 to 7,000 a month, with about half of those being individuals who've been finally determined eligible for Medi-Cal, and the other half being those who are in those temporary aid codes that I mentioned. In terms of the continuity of care requirements, which I know was of interest to the committee, per our policy, our Medi-Cal managed care plans are required to provide out-of-network provider continuity of care for up to 12 months for certain Medi-Cal benefits, which would include primary care physician services, specialty services, ongoing treatment authorizations, as well as a few other specialty providers. Under this policy, the out-of-network provider has to meet basic quality requirements and agree to a rate with the health plan, where the floor that the health plan has to offer is the Medi-Cal fee-for-service rate. We are working to try to improve these transitions with Covered California, our counties, and our stakeholders. There will continue to be these transitions, as I said, every month. We get the data a month ahead of time and then 2 weeks ahead of time, so there isn't a lot of time for people to transition, and we're trying to improve that and provide as much notice as possible, again, working with their partners at Covered California and the counties. I will stop there.
Anything from Finance or the LAO's office? Any questions? Public comment?
Thank you, Mr. Chair. Frank Mecca with the County Welfare Directors Association. Very briefly, just want to say that we're extremely grateful for the partnership with the Department of Finance and the Department of Healthcare Services on the current year augmentation to the Medi-Cal program. We worked in very good faith together to come together with that augmentation, which is critical for our ability to effectively implement the Affordable Care Act. That number is a reflection of two things, some good news, some bad. The first was a much higher than anticipated caseload increase. We put over 2 million people on the Medi-Cal program. And the second, as you know, some ongoing difficulties with a significant difficulty with the CalHERS program, which are being worked on as we speak. And so we're looking forward to working with the administration in the same degree of good faith for the budget year number. We certainly expect the work to be there in the budget year. And I just wanted to sort of let the committee know that the way the budget's constructed, a number will be coming to you in the May revise. And we look forward to working with the administration and the legislature so that we can continue the work that we've been very proud of.
Good afternoon again, Tia Orr on behalf of the Service Employees International Union. I am actually going to turn my testimony over to a number of eligibility workers we had come from different counties across the state just to express to you the gratefulness and the gratitude we have to the governor for the $150 million augmentation. It's going to make a big difference as we try to get through the demand and the things that Mr. Mecca explained. So coming firsthand, I want them to explain some of their experiences on the ground so you guys can hear that.
As they come, let us say thank you to you and ask you just to keep it brief, but we appreciate you. Thank you.
Absolutely. Elvia Malvito, Los Angeles County. I am an intake supervisor. And while we have been battling this giant beast of a thing, we have kept our heads above water, barely above water. But this $150 million is a beautiful gasp of air, but is by no means a reason to exhale. So while we do thank you for the funds, we do wish to be invited to the table so that we can tell you how to get the most bang for your buck. This $150 million can go a very long way if we have our input and tell you how best it'll serve us so that we can serve our communities. Thank you.
Thank you.
Hi, my name is Dana Brown. I'm from Alameda County Social Services, SEIU 1021, and I work in foster care. Our foster care youth have Medi-Cal till the age of 26. I know Alameda County is following this rule. I can't speak for other counties, but they do have Medi-Cal till 26.
Thank you so much.
Good afternoon. My name is Yolanda Floyd. I'm an eligibility worker from Los Angeles County with 24 years of experience. I have never experienced a program like the Affordable Care Act, and we have been able to thrive underneath tremendous pressure. We also need to be a part of the conversation on implementing the $150 million. We are the experts in this field. We have worked around every IT problem they have. We are willing to put in the time and the work, whether it be on our regular shifts or overtime. If we are part of the conversation, it will we will be a greater partner together than if we're implementing it just without us.
Thank you.
Good afternoon, Roseanne Berthrana-Rechka. I'm a program coordinator from the County of Santa Clara, and first I want to thank for the implement of the $150 million, but going forward, most of my job is dealing with the system functionality issues between the county SAW system and CalHERS. The policy changes have done one thing, increase the caseload tremendously, which obviously if you have more people to serve, you need more money to do that. But the system functionality issues have been monumental and very, the obstacles are a lot and very cumbersome workarounds are needed, where something that should be done very simply is now taking you 3, 4, 5 times as long, or maybe not even a solution for months until the functionality gets fixed, which requires supervisors to bottom line override cases on a monthly basis in order to keep people in eligibility. And so I ask you to please look forward and involve eligibility workers and people who are actually on the ground doing this work to see what kind of obstacles we have to deal with in order to find solutions for that. And it doesn't look like the solution is going to come quick. It seems we really rolled out the CalHERS systems before it was ready to fly. So it's kind of lumbering down the road with duct tape, and it just really isn't working very well from our point of view. it's not. It really needs more money and more help. Thank you.
Thank you.
Good afternoon. My name is Thelma Starr. I'm with Alameda County. I'm an ET worker, a Medi-Cal district worker. I just want to say thank you for the $150 million and the new workers that it provided. We have, which right now working in the computer system has created a lot of workarounds, and which increases more and more work and delaying service to our customers. I'd also like to say we oppose the suspension of the COLA at this time, prefer to, after you have your budget for the year 2015-16, to go back and review that. Again, I'm a Medi-Cal district worker, and I'd like to thank you.
Thank you.
Good afternoon. My name is Alidia Macias. I'm from the Ventura County. I work for HSA and ongoing, and I am very thankful for the $150 million. Right now, our office location is averaging every worker is working about 100 hours in 2 weeks with overtime. So this money will be greatly appreciated because, as many of my colleagues have said, the workarounds that have been established are being found even with us. So it would be I think it would be more efficient if you talk to workers on a daily basis and ask, what is it that you're doing to troubleshoot this? How are you getting this to work? Because even though there's implementations that are being sent to us, they don't always work. For example, one of the things that we are currently struggling with is any household that has had some type of ITC in the past, for some reason there's an error that won't pass. So this household may be requested a transfer from one county to another within 5 years, and they won't pass. It's an issue that is so simple, even though everything else aligns. So when you start talking to workers, we start talking to each other and say, well, try this. So once again, thank you. So hopefully there's more money coming to help so that everyone can be covered, and we're not getting the calls unsuspended, because we're here for our community, and our community needs our help, and we're willing to give them the help if we have the resources. And thank you for your time.
Thank you.
Good afternoon. My name is Robert Padilla. I am an eligibility worker, a frontline worker. I want to thank you for the funding that you've provided us. It obviously allows us to do what we do, but there are issues. You keep hearing about them. We need more help than what we have. Probably the big difference between you and me is I get to experience the face-to-face with the clients and the satisfaction that they've been helped. I feel like I've been blessed by them more than the Pope, because they are always very thankful for what we do. We want to continue doing it. I also want to stress that because we're facing the clients and the issues and the interface with CalHERS, and sometimes I feel like it's a Rube Goldberg system, but it is working much better than it used to. It was a due date driven system, so you get what you get when you're forced to meet a deadline. But it needs more work. We want to give you some of the input from our experiences. And I think that we have that dialogue. If you pull some of us occasionally from the field, we can give you some improvement feedback that will improve the efficacy not only of the systems, but the overall process. Thank you very much.
Thank you.
Thank you, Mr. Chair and members. Eduardo Martinez with the California Medical Association. Wanted to thank you for particularly itemizing this particular issue related to the transfer of lives from Covered California to Medi-Cal. Our members reported a significant amount of patient angst. Some patients received notices that they had to pick a new managed care plan after they received that notice in the mail. Obviously, involving 100,000 lives, it's a big concern of ours. And this is always going to be happening, as the previous speaker said. There's always going to be changes in people's life circumstances that make them eligible for Covered California or Medi-Cal. So we don't necessarily know the exact solution. We appreciate the committee sort of taking a look at this and sort of asking the right questions. We suggested something along the lines of a process that exists at the Department of Managed Health Care when you are transferring a certain number of lives from one plan to another. There's notice requirements, sort of approvals, and sort of top-down look at that from the department's perspective. Perhaps can be in play here, understanding that the timelines are probably not quite right given what Covered California's open enrollment is and what have you. But nonetheless, appreciate the committee taking a look at it.
Thank you.
Elizabeth Landsberg with the Western Center on Law and Poverty. And about the CalHERS IT system, it was referred to as an airplane, and folks love to say they were building it as they flew it. And I think we really have tried to be patient, but the IT system really has been built behind closed doors. We just started a stakeholder process. DHCS and Covered California do have a 24-month roadmap, but we haven't had adequate stakeholder input into that, and we do hope that the committee will continue to look at that issue. As to the Covered California Medi-Cal transitions, course, as Ms. Cantwell said, this is going to be an ongoing issue. We very much do appreciate that the department got. I texted Toby Douglas the day after Christmas. We had a conference call by 11 that morning. So we appreciate the department very readily addressing some of the continuity of care issues. But there are still some issues to be worked out. And just as people will be moving from Covered California to Medi-Cal, of course, they'll also be moving from Medi-Cal to Covered California. And there are both some IT and some policy issues to be worked out because state law does require that there not be gaps in coverage. None of us want to see people going through a period of uninsurance. So we look forward to continuing to work with the department on that. Thank you.
Thank you.
Right. Tam Ma with Health Access California, echoing concerns about the challenges and enrollees face transitioning between Medi-Cal, Covered California. Appreciate the department working on it. We do think we need more clear, detailed plans to ensure these smooth transitions, and look forward to being a part of those conversations.
I'd like to recognize the arrival of our colleague, Assemblymember Banta, who, like many of the eligibility workers who spoke, also represents Alameda County. Thank you, all of you, for your interest in this item. Ms. Cantwell, could you speak to, just briefly, what processes are used to gauge the expertise of those who are working in the systems to help us work through the implementation snags that have occurred?
Sure. I mean, we, certainly, as folks have said, we as an administration, with our county colleagues in Covered California, had to work very quickly to, set up the system that we are talking about. And certainly, as we've acknowledged and folks here mentioned, a lot of challenges, particularly in the first year. It is working better, but certainly there are still challenges. We are trying to work through a process. As was mentioned, we have published the 24-month roadmap that identifies what the priorities are for the system changes to our stakeholders, to our county partners, and really look forward to continuing to have those conversations about how do we make the right priorities, what can fit in when, with the end goal really being that we want people who are eligible for coverage to get on coverage as quickly as possible and without as much challenge as they've had in the last year. So we're certainly open to making sure that the right folks are in the room and in those discussions as we go forward.
Keep us posted, and we will urge that you continue to seek the expertise of those who have the most and direct hands-on experience. Thank you. Any questions on this item? Let's move on to, there's some health care reform budget change proposals. Ms. Cantwell.
Sure. So this proposal is to request to extend 6 limited-term positions in our claims processing division, our provider enrollment division, and our IT divisions. All except one are currently filled, with that one that just became vacant in December, and we're actively recruiting for the position. Some of the examples of the work that these positions do include continued new system development and updates to the systems and processes that are needed to ensure the ongoing ability to process claims in our fee-for-service system. Interpreting the policy guidance for the Affordable Care Act and the rules on the required Medicaid interfaces, so really the work with CalHERS and the county SAWS systems, conducting system analysis, providing technical requirements, and overseeing the implementation of system enhancements and the interfaces between our MEDS system, our CalHERS system, and our county eligibility systems. And finally, processing applications for the enrollment of our ordering, referring, and prescribing providers. Previously, those were not required to be enrolled in the program. They are required under the Affordable Care Act, and so we've been going through that process of making sure that those providers are getting enrolled. The request to extend these positions doesn't indicate that we're behind schedule. It just indicates that we have the ongoing need to do these, and as you heard people talk about today, the ongoing need for improvements to the systems. And so that is why we're seeking an extension of these positions, but we're not seeking that to make them permanent, just another 2 years.
Anything for finance or LAO? Mr. Bonta? Okay. Public comment? Seeing none, let's move on to healthcare reform, financial reporting, budget change proposal.
Sure. So under this proposal, we're requesting 18 3-year limited-term positions to ensure that the department's able to meet our federal reporting requirements and perform the necessary reconciliations of benefit payments with the federal government. There was one question about why 18 positions when it talks about the doubling of the workload, and so I wanted to put that in context. These resources are being requested for 2 specific areas. First, for the Federal Reporting Unit, which monitors and prepares and reconciles the federally required reporting. Currently, the staffing for this unit is 11 people. The pre-existing workload prior to the ACA implementation had already grown by 56% and was absorbed as best as possible within the current staff with assistance from other units and other managers, but the staff were working really beyond capacity. The current workload is already at an unsustainable level before factoring in all the increases related to the Affordable Care Act. This BCP would provide an additional 10 new positions to allow the staff to be able to meet the increasing requirements. So it is just about a doubling of the unit in that staff, the staff in that unit. The second is the Local Assistance Accounts Payable Unit, which processes our Medi-Cal expenditures. This includes auditing, scheduling payments with the Controller's Office, and various other responsibilities. Currently, the staffing for this unit is 10 people, and this BCP would provide an additional 8 new positions to this unit to allow the staff to be able to meet the increasing expenditures workload. For example, our managed care invoices doubled under the ACA, and so in order to be able to meet those timelines, make sure payments are going out, we really do need these additional resources.
Finance or LAO's office? Questions from the committee? Public comment. Sir, are you speaking on public comment? Okay, thank you. Let us move on then to the hepatitis C drugs proposal.
Sure. So, as folks are well aware at this point, several new hepatitis C drugs have recently been approved by the Federal Food and Drug Administration that do provide a cure for the hepatitis C disease. However, these drugs do cost approximately $85,000 per treatment regimen. There are many people enrolled in the Medi-Cal program, as well as individuals who receive care from other state or county agencies and programs who are infected with hepatitis C. The governor's budget proposes to reserve $300 million to account for the fiscal impact from these high-cost drugs, and the administration, under the leadership of our Health and Human Services Agency, is convening a work group to discuss utilization guidelines and payment structures. In terms of the status of the work group, as I just mentioned, the work group is being convened by our Health and Human Services Agency, and for the first step, agency is calling together in March the affected state agencies and our county partners who have responsibilities for providing health care and are therefore the most likely to be impacted by the cost of these drugs. So for this first step, the membership includes CalPERS, the California State Association of Counties, the Sheriff's Association, Covered California, the Department of Corrections, Department of Healthcare Services, the Department of Managed Healthcare, the Department of Public Health, the Department of State Hospitals, Veterans Affairs, the University of California, the Department of Finance, and the Department of General Services. At this point, beyond that first step, agency is still working on what will the next steps of the work group be and how will it be expanded to include other individuals. And then finally, there was an additional question related to evidence about the concern about reinfection amongst individuals after they've been cured. In developing our guidelines, one of the issues that we and other healthcare providers need to consider is patient compliance with the treatment. And compliance can mean many things, including completing the course of treatment as required, or changing behaviors that may lead to reinfection, such as ongoing drug use. Evidence does show that reinfection rates for individuals who are ongoing drug users is 2 to 3 times higher than for other populations who are treated for hepatitis C. And although these studies were done prior to the emergence of these new drugs, so therefore we do think it's an issue that will need to be looking at ongoing and having studies of the impacts, but it's also one that should be considered in developing the treatment guidelines. And then there was a third question that I will defer to the Department of Finance.
Thank you. Jennifer Lopez, Department of Finance. The purpose of the provisional language allows the administration to recognize that there are costs related to these high-cost hepatitis C treatments. However, it's unclear the overall fiscal impact to each affected department. After convening the work group, as Mary has just spoken on, and once costs to each entity are determined, the administration would need to ensure that each entity has budget authority to cover the costs. Therefore, the purpose of the provisional language is to allow the Department of Finance to adjust items of appropriation to the general fund and the federal trust fund and allocate the $300 million set aside for these high-cost hepatitis C medications. In response to LAO's suggestions, the administration is not opposed to a 30-day notification period. However, the administration does want to point out that a 30-day legislative notice period may delay these allocation payments to the departments. The administration does, however, agree with providing the legislature with the list of programs receiving the funding, the amount of funding, and what the funding will be used for. Thank you.
Anything from the LAO's office?
We find that the administration's approach of budgeting the unallocated set-aside is reasonable, but we note that there is uncertainty as to whether the amount of the pro set-aside is appropriate, so we'll continue to look for additional information on the cost of the drugs and utilization and continue to evaluate this. With regard to the provisional budget language, we note that an expedited review could be asked for, and we do find that the language should be modified as discussed to provide the legislature with sufficient oversight authority.
Thank you. Questions from the committee? Mr. Chu.
Thank you. First of all, I want to thank the administration for tackling this challenging situation involving hepatitis C. And as you know, this is one of the more surprising and challenging, I think, elements of the budget. My first question is, if we're assuming $300 million, $85,000 per patient, that's estimated about 3,500 patients, which we have heard may be sort of tip of the iceberg. And I want to get a sense, what sort of estimates are there and what the potential longer-range costs are around hepatitis C? How did you pick $300 million to start with? Could you give us a sense of what potential budget risks are there and why you ended up at this particular number?
Sure, so I'll start and certainly then turn it over to my Department of Finance colleague. One thing I do want to note is that there is funding for Medi-Cal program in our Medi-Cal budget separate from the $300 million that was based on our estimates at the time. So the $300 million doesn't reflect the total estimated cost. It was really a set aside to deal with the uncertainty that all of our departments, and I'm assuming, and Department of Finance can comment, that all of the departments probably have some funding already built in. So we built in some fairly significant funding into our Medi-Cal estimate, but part of this was to allow for that potential that we didn't know exactly how much was this drug was going to be utilized or needed for exactly the reasons that you've laid out. The other thing to note, just when it comes to the Medi-Cal program, is that since it is a federal matching program, to the degree that that funding is used to fund Medi-Cal, it's not just if it was all to our department, which it won't be, but if it was all, it would at least be doubled, given the federal matching, and in some cases we get, for the expansion population, 100% federal match. So that's part of the analysis from the Medi-Cal perspective, but I'll turn it over.
By the way, do you have a total cost figure for what will it cost California in the next year or two to pay for this?
I think that's partly what the work group is trying to work out, is what is the potential scope of the issue and what are the potential costs.
Do you have any ballpark?
I don't, but we can certainly take that back and see where we're at.
Yanning of Department of Finance, Mary is correct. We don't have an actual estimate yet in terms of what the cost would be statewide for all the impacted department. In terms of the $300 million, how we came about with that, that was the initial assessment that we had, internal conversations between all the departments that are impacted. We're unclear at the moment, unclear what the cost would actually be. That's why we have to work, the stakeholder work group. We're going to work through that process, and hopefully at May revision we'll have a better idea what the actual cost would be.
And then a second question I have is, I know that in the past, the Department of Healthcare Services, that you do, when it comes to other high-cost drugs, attempt to negotiate rebates with the pharmaceutical companies. Could you talk about your efforts in this area and what sort of results you got?
Certainly. So a couple of things. One, under current state law, we are allowed to negotiate rebates for drugs that are covered in our fee-for-service program and drugs that are covered through our county organized health systems managed care plans. We previously have not had the ability to negotiate supplemental rebates for the rest of our managed care plans. Last year, the legislature passed and the governor signed a trailer bill that allowed certain high-cost drugs that are being covered by our managed care plans to allow us to negotiate rebates on those, assuming certain conditions were met, including how we reimbursed health plans for those. The hepatitis C drugs are the first drugs that we have in that category of separate reimbursement and separate guidelines that we're issuing to our health plans. We have been in contact and negotiations with the manufacturers and are close to having a rebate that we think can apply to our fee-for-service and county organized health systems. Unfortunately, given the ongoing uncertainty on the rest of our managed care plans in terms of our rate development, our rates have not been approved by CMS yet. That will be a second step, but it is something we're pursuing actively, and hopefully, we believe in the May revision, we'll have something to share.
Okay, in this area of hepatitis C?
Yes.
Okay, because in the staff analysis it states that your department had been engaged in efforts to negotiate rebates, but to date their efforts had been met with virtually no interest by the pharmaceutical industry.
So
are you suggesting that has changed?
Last time we had the conversation.
I just want to be clear about that.
Yes.
Okay.
It has changed. We have been having recent conversations.
Breaking news.
That's helpful. a different question. Could you talk about the discrepancy in the cost of these drugs in California and the United States versus countries overseas? I know that there are pretty significant price differences.
I can take it from our perspective. I mean, part of this, right, is that in certain cases like this, where you have drugs that are specialized, it's it's what is the ability and the leverage of the different parties. And at this point in time, we have seen other countries be able to have a lower price point, but that has not been the case here in the United States, given the structure of how we negotiate prices.
Okay. And then my last question is to the LEO. I understand in the report it says that as more information becomes available regarding the cost and projected utilization of these new hepatitis C drugs, we'll provide the legislature with an analysis of likely costs. Could you talk a little bit about what you're going to be doing to do a fiscal analysis of this cost? What sort of factors are you going to take into part? How is that going to differ from what the work group is doing?
We were particularly looking at what amount would be appropriate to set aside, because as we noted, there is considerable uncertainty with regard to that. So we would look for additional information in terms of whether the department is able to negotiate rebates and what that would look like, as well as in terms of utilization. Our understanding is that the guidelines for which patients should be treated with these high-cost drugs are being revised, so we would look to see what the revised guidelines look like and get a better sense of what utilization would look like based on those guidelines.